Okay, now, um, we went over the screen exam with Julie here, and um, from that screen exam, um, you should be able to determine what to examine in detail. Is it a low back problem? Is it an SI joint problem? Is it a hip problem? Or is it an extremity problem? So your screen exam at this point in time is your low back exam, and let us assume now that we have determined that it is a low back problem, and we want to go on from there and determine how we're going to treat that problem. Before we do that, we should consider a few things that are low back contraindications. You should be aware that upper lumbar problems are rare in the low back. It is a very common place for fracture and metastatic disease. So anytime you determine from your exam that the problem is coming from, let's say, L1, L2, L3, always tread lightly. That's a yellow flag because it doesn't occur very often. And be sure you're not dealing there with something more nefarious in terms of metastatic disease, fracture. I've had aneurysms in those areas. So it's unusual to have to treat the upper lumbar. Mid-lumbar, L4, L3, L4 problems, a little more common, where you'll see most of your symptoms are coming from those segments, in other words, the quad, anterior thigh, that kind of thing. But the large percentage of your low back problems come from the lower lumbar region, both bony and soft, or bony and disc. But you still have to be concerned about dysfunction in the low back. You come in. Go ahead. Bowel and bladder dysfunction are relative to sacral root compressions, and you have to be concerned about those in your history, and they are total red flags. You don't want that. You don't want those are problems you don't treat. Those are surgical conditions that have to be addressed immediately. Not only bowel and bladder, but problems that saddle type anesthesia, anal numbness, all those kind of things. Lower sacral root problems are pretty serious usually, and those people need to be totally evaluated for surgery. Referred back pain, you always want to be concerned about that, and a lot of times what you see with referred back pain is a negative exam but continued symptomatic pain. And the areas that you have to be concerned about are gynecological referral from female structures is very common. Menstrual pain and low back pain occur very commonly together. Ovaries, fallopian tubes, all those things in the reproductive tract of females can be causing referred low back pain. Upper urinary tract disease such as kidneys and stuff also refer pain to the low back, and prostate in men. So all those things that are positive for low back pain but contraindicated for low back treatment, you have to be aware of. So always be aware of your yellow and red flags in the low back. And a lot of times these problems come up in the history more than they do any place else. In other words, people have night pain, they have constant pain, they have pain without movement, they may have secondary metastases. You have to understand from your exam whether a patient has had cancer somewhere else before and that you may now have a secondary deposit, that kind of thing. And of course you need medical help on those things. Those people need to be managed. by other people. So, beyond that though, now we want to decide whether what you're going to do with these people. You've examined them, and you've determined now that it is in their low back, and you determine that you do want to treat them. So we will look at that and see what those particular classifications of treatment involve. And I can tell you from experience that most of your patients that have treatable problems will respond to these exercises that are put forth by McKenzie. Many of, that will cover the great majority of people you treat. Now, I'm not saying that manipulation never works. I'm not saying that you shouldn't use it. I'm not saying that there aren't secondary problems associated with primary issues you're treating, like a sacroiliac joint dysfunction, secondary to a primary disc problem. I think that occurs frequently. But for the most part, if you just take your patients and try to classify them properly and treat them as per the classifications that you determine they fit into, you'll be successful. So let's go on from there. So, treatment. What are you going to do with these people? You have people that you're going to classify as extension principle, people you'll classify as flexion principles, people you'll classify as lateral shift correction, and then others. Your extension principle, your primary symptom for putting someone in an extension principle is what? It's pain that is made worse by flexion postures, and we're talking about mainly sitting. Sitting exacerbates their pain. So those people are extension principles. The people that have more pain with walking and upright postures are flexion principles. These people you're going to treat with flexion. These people are mainly your disc problems. These people are mainly your bony entrapment problems. Lateral shift corrections, we do need to talk a little bit about them, and as we get into some of McKenzie's stuff, I will discuss this in a little bit more detail. But let's go on from here and see what we're dealing with. The extension principle, pain is worse with prolonged sitting or rising from sitting. That's your main thing right there. It's worse with driving, stooping, bending, other flex postures. A lot of people will tell you that they have relief from sitting, but then they tell you, but if I sit very long, it gets worse. And they will tell you, you say, well, how do you do driving the car? And they say, well, I can't drive very far because it's worse, and that's a sitting posture. So for the most part, these two things will be positive in terms of classifying a patient into an extension principle. Generally speaking, these people have more flatter backs, and they usually have a decreased lordosis, but not always. They sit slouched. Everybody sits slouched, at least initially, to open the intervertebral frame and open the posterior parts of the vertebra to get some relief. Back bending generally centralizes these people's pain, and forward bending usually peripheralizes their pain. Now let's talk about the peripheralization of pain phenomena. The peripheralization of pain phenomena has to do with what you're affecting within a patient with the movements that you're doing. If you just think about it as a disc protrusion that is coming out into the posterior longitudinal ligament area, and as that protrusion hits the outer annulus and the outer the dura, you have local pain there. And then when the protrusion gets a little further out into the canal and into the intervertebral foramen, it starts to put pressure on the nerve root, or as the pressure goes from the outer annulus to the posterior longitudinal ligament to the dura to the parenchyma of the nerve root, everything gets worse and everything goes down further. So that when you have pressure just on the outer annulus and the posterior longitudinal ligament, the pain probably is mainly limited to, let's say, the posterior longitudinal ligament or the outer surface of that. And then as you start pressing in on that further, it goes down into the buttock area. And then you press out further on that, it goes into the sacroiliac area when you hit the dura. And then when you violate the dura and go into the nerve root, it goes down the leg. And the further the protrusion goes into the nerve root, the further down the leg it goes. And then when you get into the parenchyma of the nerve root, then you're starting to get into a numbness and a lack of conduction, of peripheral conduction of afferent fibers, and that's the peripheralization of pain phenomena. And then the centralization of pain phenomena, conversely, can be just the reverse of that. Whereas when you're doing things to centralize their pain, you're doing something good. When you do things to peripheralize their pain, you're doing something bad. So that's the peripheralization of pain phenomena, and we use the peripheralization of pain phenomena almost in everything we do, with anything that has to do with nerve tissue. And that is, that guides our treatment. We don't ever want to do things that cause peripheralization of pain. One thing I will tell you, though, that there are times when you will peripheralize the pain with something just because you've started it too soon. And by that I mean, let's say we have a radial bulge at L5S1, and you extend them, and you cause the radial bulge to pinch off a little more, which will peripheralize their pain. And you get that because there's so much congestion in the intervertebral foramen that there's no room for that to occur. And so you do peripheralize their pain. But once that inflammation starts to settle down, that type of radial bulging and increase in radial bulging will not occur. And so you can get correction once that inflammation goes down, and you won't have the peripheralization of pain occurring. So that's centralizing pain, peripheralizing pain. Backward bending on extension principles many times will centralize pain. Now I do give you the exception there of the radial bulge, because if you make that radial bulge a little bit bigger, you're going to peripheralize their pain. But it doesn't mean that you're doing the wrong thing so much as it means you're doing it too soon. The forward bending, causes a lot of increased tangential strain, causes a lot more bulging posteriorly, and this obviously will cause more protrusion into the nerve root, into the dura, into the parenchyma of the nerve root, and you'll get peripheralization of symptoms. Now with these people on the extension principle, generally speaking, the repeated forward bending makes them worse, repeated backward bending makes them better. But to be truthful with you, the main thing here is right here. This is what you want to hang your hat on for the most part. How are they with sitting? When sitting causes increased pain, that's generally a disc, and you've got to extend those here. So this is the general thing you see, and this specifically is what you want to hang your hat on right here. Now, flexion principle patients, they're relieved by sitting, and they're worse with standing than walking. Many times they'll have an increased lordosis. They sit slouched to get comfortable. They usually have an decreased range of forward bending. And lordosis many times doesn't even flatten with forward bending. They'll go down without reversing their lordosis. Repeated forward bending increases their pain. Sustained forward bending, or repeated forward bending decreases their pain. Sustained forward bending increases their pain. And the reason this occurs is because when you put a stretch on a tissue for an extended period of time, that stretch on that tissue will cause them to have some pain. So repeated backward bending increases their pain, sustained backward bending increases their pain. All these things basically are saying that extension postures will make them worse. Walking is an extension posture, and like I told you with the screen exam, when you walk, you're extending your lumbar spine every time you take a step. Because as you take a step, you put a stretch on the iliolumbar ligament, you put a stretch on the psoas muscles, and you force yourself into extension every time you take a step. As soon as you extend the hip on your step, you increase the lordosis. These people do not tolerate increased lordosis because you make too many bad things happen when you extend those segments, like we said in earlier parts of the presentation. So that's what's happening here. Basically speaking, you have a claudican pain behavior, and what that basically means is every step they take, every time they extend more and more, they get more and more congestion in that nerve root area. And there is some school of thought that indicates that this claudican pain behavior is actually claudication. And it's claudication in the lumbar area rather than claudication in the foot area. So it can be both. And at any rate, these people classically tell you that they have more pain with extension postures. Okay. Now let's look at lateral shift. When we did the screen exam, we did some examples of Julie and showed what a lateral shift looked like. This guy right here, of course, has a lateral shift. You see a little bit more space in here. The hips are shifted over this way, and he probably has a lateral shift. Now, what causes this lateral shift? And the lateral shift is a loss of side gliding to the opposite side. Side gliding, and when you do side gliding, it alters their symptoms. In other words, a lot of times you may not be able to determine whether a lateral shift is real or it's just something that's there and has always been there. Because lateral shifts can be permanent if they're left alone for an extended period of times, mainly from soft tissue accommodation. However, if you look at Mackenzie here, he's doing side gliding with this patient, and he's determining whether the lateral shift is relevant or not. There are two ways to do that. If you have a lateral shift such as this, and you try to shift them back into neutral, and it affects their symptoms, or you shift them more and it affects their symptoms, that usually means the lateral shift is in fact relevant. The other thing you can do is to side glide them into the lateral shift, and that usually will affect their symptoms and make them feel worse. So the first thing you do with a lateral shift is to determine whether it's a relevant lateral shift or it's an irrelevant lateral shift. And then once you have determined that in your mind that it is relevant, then you want to determine in your mind what's causing it. Now, the schools of thought on this are varied. Some people will tell you that, or some people feel that, you know, if you have a lumbar segment that has a bulge on one side of it, like so, that will force this vertebra over this way, and you're going to get the trunk deviating in that direction just because of accumulation of more tissue and material right in here, in that lateral side. So that would cause a lateral shift, and if there's a lot of tissue on this side, then that means there's pressure on these tissues all through here. which means their symptoms are probably coming from that side. So the lateral shift basically occurs to the opposite side. If the trunk goes to the opposite side of the pain, that's usually a pretty good prognostic sign. And the reason for that is because the other philosophy of why a shift occurs is that if the material here on this side of the pain is already herniated out over into this area here, and this occurs, now you have a lateral shift to the same side. And when that lateral shift occurs to the same side, that means that this material is already herniated out of there. There's not much tissue in here to hold the bodies of the vertebra apart, and you get a shift to the same side. That generally means that the cat's out of the bag and you're not going to be able to do a whole lot with them. But you try. And always using the peripheralization pain phenomenon, you're fairly safe in what you do. Now, the other thing that occurs in the low back and the shift areas is a compensatory shift in a flexion principle. Now, a compensatory shift in a flexion principle is very simple because these people have foraminal encroachment, and in order to open this intervertebral foramen, they just side bend to the opposite side automatically. And that allows that intervertebral foramen to open up and accept the increased pressure, or decrease the pressure on that disc, on that nerve root. Now, if this, in fact, I always tell my students that if you do in fact have a flexion principle with a shift, do not try to correct that shift, because it's an accommodation shift. It's accommodating to that nerve root being pressurized, so the patient, if the nerve root's on the left and it's coming out of the intervertebral foramen on the left, if you side bend a little bit to the right, it opens that foramen up and gives them a little more room. Now, if you side bend to that side, you're going to crunch down on the root more, and you really can't do that. Once you do it, you're going to be peripheralizing pain, and you're going to automatically know right away that you're doing the wrong thing, because you don't want to increase the pressure on that root by decreasing the size of the intervertebral foramen on that side, or sticking the foramen with a spur that's there that wouldn't normally not stick it if you open the foramen up with side bending on the side. So long and short, if it's a flexion principle and the patient has a shift with it, disregard the shift. Just treat them as a straight flexion principle. Okay, so lateral shifts. That's probably why we have lateral shifts and how we approach them. McKenzie feels that you need to correct this before you go into extending the patient. And his philosophy basically is that you want to get the material pushed back in a little bit before you can extend and get it in going forward. Don't know whether that's true or not, but functionally, that is what seems to happen. So what we do, if you have an extension principle that has a lateral shift, you try to get the lateral shift corrected first. Now McKenzie, he will do manual corrections, but I would suggest that unless you are really sure about what you're doing, that you kind of stay away from these things, at least initially, because you don't need to do them. You can correct lateral shifts with other types of maneuvers, and what we do is we just have the patient stand in a doorway. Let's say they got a trunk shift to the left, hips are going to the right. You get them in a doorway and have them just actively correct their shift. And when you do that, again, you have to use your peripheralization of pain phenomena, and that has to do with, as you shift, if they start to get more budding pain as they try to get out of the shift, you're probably pinching, and you can't go do that much. So you just have them work on it and work on it and work on it, but not peripheralize their pain. The pain can start to peripheralize, but as soon as it does, you know that's the that's the stopping point for the shift correction. And generally speaking, patients that you give them to do the shift correction exercises, you have them do it 8 times a day in a doorway, and the next time you see them, many times the shift is gone. and you can begin your extension treatments. Okay. I work on if it's not gone, then I try to do some manual corrections myself, and I don't generally pull them over real hard like Mackenzie does. You can use your hands you get them in the doorway, and you can use your hand pressures to help them try to shift away from that shift. And as long as they're not peripheralizing their pain, you'll usually get them over. In fact, sometimes you can overcorrect them. And once you get them overcorrected or corrected, you can start in on the extension routine. So, that's our lateral shift principle. And the lateral shift principle will develop into an extension routine unless the lateral shift is accompanied by a flexion principle, in which case you disregard it and start flexion right away. If you have the lateral shift with extension principles, you try to get that corrected first before you start them into an extension routine. And the extension routine, as we show here, what we generally do is have them do prone lying. Sometimes you cannot even lie them prone because of the radial bulging here. Many times what happens is the radial bulging will prevent you from getting any kind of extension postures in the prone position. So sometimes you have to actually start with a pillow underneath their tummy to get them kind of flat and let them start on a extension posture, and then eventually get the pillows come out, and then eventually get the elbows under the chest here so that you get some lordosis. And we have them lie in one of these positions for up to a minute each, as long as they're not getting peripheralization of pain. Once they can lie with the pillow under them, or with just flat, if they can lie that way for a little bit, we start getting the elbows tucked underneath them for a little bit. And you do these things sequentially. You may have to not do too much of it initially, but as they get better, they get higher and higher and higher on their prone extension postures. Once they can do this with their elbows even tucked into them, and sometimes even synonymous, or at the same time we're doing static extension, we'll start on some flexion or extension exercises. And what we generally do with the extension exercises is start them with push-ups. And this is obviously a very aggressive push-up. You want it to be passive as possible because you don't want to compress tissues by contracting the muscles, and that is very difficult many times. But what you do here is, I usually start with the hands way out here, and the chest may just barely get off the table, up and down, and just pump that, as long as you're not getting peripheralization of pain phenomena occurring. And then as they're able to do more extension, they come up higher and higher and higher. And this particular exercise, you go from prone lying to press-ups and then to back bends. This is the most aggressive extension you can do. Of course, we very rarely get patients that can do that much extension. But we do, this is the last exercise we would do in an extension principle. We have them do standing back bends. Once they can do this, they're usually in pretty good shape. You've gotten better. If they are workers, or they're doing some kinds of mechanically dangerous lifting, then many times we'll teach them to do this before they do have to lift. You know, if you're dealing with someone that's doing lifting a refrigerator or furniture, you have them do some extension first to make sure the disc is not in a bad position. Now, we also recommend extension postures all the time. We tell them not to sit any more than they have to sit. This is a when they have to sit, we tell them to sit with a lumbar roll. So all treatment actually begins and ends with a lumbar roll and sitting. You always want them sitting in extension. You don't want them flex sitting.